In today's lecture, we will be discussing cyclooxygenase inhibitors and going over in a little bit more detail NSAIDs and acetaminophen. The drugs we're going to be discussing in this chapter have the ability to provide pain relief and also the reduction of inflammation and even fever. And this is through a process that inhibits cyclooxygenase or COX. Remembering that COX is an enzyme that promotes conversion of other compounds that further promote the inflammation process and can sensitize nerves to painful stimuli. So if we're able to inhibit cyclooxygenase or use COX inhibitors, that's the name of the drug class we're talking about, then we can help to, again, reduce fever, inflammation, and relieve pain. So all the drugs in this chapter, in this presentation, will be working through the inhibition of cyclooxygenase. Okay, so that's a mechanism of action. So the enzyme that converts COX into a compound that could cause inflammation and pain, this enzyme converts to arachidonic acid and then into prostanoids, prostaglandins, and other related compounds like prostacyclin and thromboxane alpha 2 or A2. So in order to understand the drugs that inhibit COX, we also have to understand how COX itself works. So cyclooxygenase can be found in our tissues, and it's a process or it's involved in a process that can help regulate different things in our body. Like for instance, at the site of an injury, that tissue area, COX is there, it catalyzes the synthesis of prostaglandin E2, but also prostaglandin I2. This will then promote inflammation and sensitize the receptors that will tell our brain that there is something painful, right? So it's receiving that painful stimuli. However, in the stomach, COX promotes the synthesis of prostaglandin E2 and prostaglandin I2 also, and this helps to protect our gastric mucosa. The three mechanisms that I want you to realize is the reduction of secretion of our gastric acid, but also the increased secretion of bicarbonate and other cytoprotective mucus. It maintains the submucosal blood flow. Now, in platelets, COX also does something. It promotes the synthesis of thromboxane A2, and this stimulates platelet aggregation. So in blood vessels where COX is going to promote the synthesis of prostacyclin, which causes vasodilation, you will also see that COX has potential in our blood vessels. What about the kidneys? In the kidneys, COX catalyzes the synthesis of prostaglandin E2 as well as I2. It promotes vasodilation and it helps with renal maintenance of blood flow. COX also is related to our brain. In the brain, COX-derived prostaglandins can mediate fever, contribute to the perception of pain. We also can find COX-derived prostaglandins in the uterus, and they help promote the contractions when a baby is at term. With this understanding, we can see that we need to have an appreciation that prostaglandins, prostacyclin, thromboxane A2 all act locally, and the compounds don't affect sites that are distant from where they're made. So they are acting independent of the other areas where COX can be found in the other tissues. Now there's two forms, and you can see here we either have the good COX, which is the inhibition of COX-1, or the bad COX, which is the inhibition of COX-2. Now COX-1 is found in particularly all the different tissues where it mediates all the different chores. right? That keeps the housekeeping. Now, important things that are going on in these housekeeping chores are protecting the gastric mucosa, supporting the renal function, and platelet aggregation. Those are all important to COX-1. In contrast, however, COX-2 is produced mainly at sites of tissue injury only, and this is mediating inflammation and sensitizing receptors to painful stimuli. You can find COX-2 in the brain as well. This is in the brain, as well, and this is where the brain is going to mediate our fevers and also, again, contribute to the perception of pain. We can find COX-2 in the kidneys, supporting renal function, also in the blood vessels, promoting vasodilation. And COX-2 can also be found in the colon, and this is a contributing factor to colon cancer. So going back to why COX-1 is called good COX and COX-2 is called bad COX. Because COX-1 is primarily involved in mediating the beneficial processes and COX-2 primarily mediates harmful processes, this is where it got the name good versus bad COX. Now, within the two different types of COX-1 and COX-2 inhibitors, we also need to classify how they inhibit. So they either will fall into two major categories. The first one is drugs that have an anti-inflammatory property. And then the second category is drugs that lack anti-inflammatory properties. Now, the first group, drugs that have anti-inflammatory properties, we'll call them non-steroidal anti-inflammatory drugs. So very easy to remember. The NSAIDs. What is representative of this? We have ibuprofen like Advil and Motrin, aspirin, naproxen, brand name Aleve, and Celebrex is the brand name for celecoxib. Now, drugs that lack anti-inflammatory properties, which is the second class, this only has one drug, Tylenol, brand name for acetaminophen. And acetaminophen can reduce pain and fever, but it doesn't have that ability to provide anti-inflammatory reactions. Okay, so it cannot suppress inflammation. Now we have to further divide or subdivide the NSAIDs. Okay, so now we have a different classification. So we either have first-gen NSAIDs, these are conventional NSAIDs, and then we have the second-gen NSAIDs. These are very selective to COX-2 inhibition. Okay, so these are the COXIBs. Now, the first generation will inhibit COX-1 and COX-2 because they're non-selective. The second generation agents inhibit only the COX-2. Because first-gen agents inhibit both COX-1 and COX-2, they are not able to suppress pain and inflammation without also posing a risk for the serious side effects. Remember, we have COX found in our GI, in our blood vessels, and in our renal system, right? So this is why the COX-1 inhibitors can also cause gastric ulceration, bleeding, and renal impairment. The good news is, to contrast the COX-1 and first-gen NSAIDs, we have the COX-1 second-gen NSAIDs. And in theory, they can suppress pain and inflammation, but they're going to have fewer adverse side effects. But in reality, COX-2 inhibitors appear even less safe than the first-gen agents. And this is because research has shown that there is an increased risk for MI and stroke with the COX-2 inhibitors. So they may be safer on gastric ulcerations, bleeding, and renal impairment, but they are linked to increased risk for MI and stroke. So let that be a guiding principle when you are selecting a COX inhibitor. This slide here, table 57.1, does a great job summarizing what we just talked about in terms of which COX isoform is located where. So you see here that the COX-1 isoform can be found in the stomach, the platelets, and the kidneys. COX-2 isoforms can be found in the blood vessels, also the kidneys, sites of injured tissue, brain, and within the colon and the rectum. And now, in relation to the location, you can also see the reaction product that forms when COX is activated. And in this response to the reaction product, we will see what you're looking at in the fourth column, right? So in the stomach, if we don't inhibit COX, and COX is doing what it's supposed to do with no inhibition, then the response that we're expecting is increased bicarbonate secretion, mucus production, a decrease in stomach acid, and helps with submucosal blood flow. When we provide a COX inhibitor, a COX-1 specific inhibitor, we might make the patient, or the patient may be more prone to gastric ulceration. In terms of platelets, the response to COX activation is platelet aggregation. But if we give them a COX-1 inhibitor, we may help protect against MI, but we could also increase the tendency for bleeding. COX-2 on the blood vessels activated will promote vasodilation. Now, if we give a COX-2 inhibitor, this can actually cause vasoconstriction. So you see here, this is the reason why this COX-2 inhibitor may promote MI. In the kidneys, where we can find both isoforms, COX-1 and COX-2, activating prostaglandins, what we're looking for and expecting is the maintenance of our renal functions like vasodilation and perfusion. If we give a COX inhibitor, we may increase the risk for renal impairment. At the site of injured tissue, COX-2 becomes activated, activates prostaglandin, and can cause inflammation and pain. And this is the reaction, a natural reaction to the site of injury. By providing a COX inhibitor, a COX-2 inhibitor specifically, to a patient, what it will do at the injured site is reduce inflammation and provide an analgesia effect to that pain. In the brain, it's also allowing for fever and pain in response to COX-2. But if we inhibit it and provide a COX-2 inhibitor, we're providing analgesia and also fever reduction. In the colon, COX-2 helps to respond by activation and responding by promoting colorectal cancer. However, if we give a COX-2 inhibitor, this will actually promote colorectal cancer protection. I'm a big fan of Table 57.2 in your textbook as well, because it gives you at a glance the principal indications for each of the drug classes, the adverse effects of the four major types of COX inhibitors. So you're looking first at the first gen NSAIDs, like aspirin. And then next, you're going to look at all other types of first gen NSAIDs, and then second gen NSAIDs, the COXIBs, and then lastly, acetaminophen. And if we can just look really quickly, so most of them have a very similar profile. So let's look for the things that are not similar. So for inflammation, remember that NSAIDs are anti-inflammatory. Acetaminophen are under the class of non-inflammatory COX inhibitors. The next thing I would say is if you look at second generation NSAIDs, they are not going to provide fever reduction or stroke or MI prevention. Acetaminophen may bring down a fever, but it's not going to provide prevention of MI and stroke. Now, looking at adverse effects, acetaminophen will not have an increased risk for gastric ulceration or renal impairment. So for patients that have GI implications or renal implications, that you still need to have a way to bring down fever or pain, you may want to use acetaminophen versus an NSAID. For patients at risk for bleeding, you can use a second generation NSAID or acetaminophen. And for those patients that have liver damage that have been caused by an overdose of perhaps NSAIDs, acetaminophen would be your next go-to COX inhibitor. Now let's look at the adverse effects of cyclooxygenase inhibitors or COX inhibitors. What are the most common side effects? The GI effects are actually the most common that are associated with gastric distress, heartburn, and nausea. It can help reduce the side effect if you take aspirin with food or with a full glass of water. So this is something that you can teach your patients. Taking a COX inhibitor also has the risk for causing occult GI bleeding, and this occurs pretty often. Most of the times, the amount of blood that's lost each day is pretty insignificant, however. But with those patients that are chronically using aspirin, that cumulative amount of blood loss can actually produce anemia. Long-term aspirin, even in very low doses, can cause life-threatening gastric ulcerations, perforations of the GI system, as well as bleeding. And they result from 4 causes. There's either increased secretion of the acid or the pepsin, or a decreased production of the cytoprotective mucus and bicarbonate. So those things are good for us. There might even be a decreased submucosal blood flow. And actually, aspirin can also cause direct irritation on the gastric mucosa. Now, the first 3 things that we talked about, these are secondary to the inhibition of COX-1, right? So direct injury to the stomach is usually because the aspirin preparation that the patient has been taking dissolves very slowly. So the slow dissolution of the medication, specifically in this case aspirin, starts to become entrapped in the folds of our stomach wall. This allows for prolonged exposure more than what is necessary. And because there's high concentrations of the drug trapped within the stomach wall, this is directly irritating the gastric mucosa. Because aspirin-induced ulcers are oftentimes asymptomatic, perforation and upper GI hemorrhage usually occurs without any premonitory signs. So hemorrhage is going to be due to the very late stages of erosion of the stomach wall, and also in part to the action of platelet aggregation being suppressed, right? So we also have suppression of platelet aggregation. Other things that increase the risk for ulceration will include bleeding, because aspirin promotes bleeding by inhibiting platelet aggregation. You actually can double bleed, or let's say, for instance, if you take 2 325 milligram aspirin tablets, which are the normal regular doses, you can actually double the bleeding time for as long as a week. Remember, platelets are unable to replace aspirin inactivated cyclooxygenase. So the bleeding time is prolonged for the life of that platelet. Because of its effect on the platelets, aspirin is contraindicated for any patient that has a bleeding disorder. So let me say that one more time. Aspirin is contraindicated for any patient that has a known bleeding disorder. For instance, patients that have vitamin K deficiency or perhaps hemophilia. So to minimize the blood loss, During childbirth and elective surgeries, some high dose aspirins have to be discontinued up to a week before the procedure. There's no need to stop aspirin before procedures with very low risk for bleeding. So, a question that I often get is, do I need to stop my aspirin before a dental procedure or before some type of dermatologic or skin procedure? The answer is no, right? So, overall, you need to leave that up to the progression of the provider, but in most cases, regular dose aspirin does not have to be stopped for these minor procedures. So, in most cases, when you use a low dose aspirin, like an 81 milligram, we're using it to protect against thrombosis. And because we need this protection, it shouldn't be interrupted for elective surgeries or dental procedures. So, those patients that are on 81 milligrams of aspirin, because maybe previously they were at risk for stroke or they've had a stroke, they don't need to be taken off aspirin for those minor procedures. However, you always want to use caution when aspirin is used in conjunction with other anticoagulants, and perhaps question why you would need an anticoagulant and an aspirin. But sometimes patients don't realize that aspirin also has these types of properties and puts them at risk for bleeding, and they may be taking aspirin for pain relief, not knowing that it also should not be taken with their anticoagulant. For a patient that takes a daily aspirin, high blood pressure increases their risk for hemorrhagic stroke, even though aspirin protects against ischemic stroke, right? So when you are asked about aspirin and stroke protection, you want to make sure that you are differentiating and telling your patients the difference between a hemorrhagic versus an ischemic stroke. Aspirin's good for ischemic stroke protection, but also increases the risk for hemorrhagic stroke if the patient already has increased blood pressure. So how do we reduce the risk for hemorrhagic stroke? We need to help our patient to maintain a low blood pressure. Preferably, the lower the better. However, they need to maintain at a minimum of 150 to 90 millimeters per mercury before trying or considering starting a daily aspirin. Lastly, in terms of renal impairment, aspirin can cause acute yet reversible impairment of renal function, or AKI. And this can actually result in fluid retention, salt and water retention, leading to edema. Clinically, significant effects are most likely in patients that already have other risk factors, like they're advanced in age or they have other existing renal impairment. If someone also already has hepatic cirrhosis or heart failure or at risk for hypovolemia, they're going to be at a higher risk for renal impairment. How does aspirin impair our renal function? Remembering again that it's working specifically on the COX-1 in this situation. It's depriving our kidneys of prostaglandins. Prostaglandins are needed in order for our kidneys to function normally. The development of renal impairment is going to be first, you're going to see if you are suspecting renal impairment, you're going to be first notified by a reduction in urine output, maybe weight gain, even with the use of diuretics. Or you're going to look at their serum creatinine and their BUN and look at that ratio to see. And this is going to help you to notice quickly that renal impairment is starting to develop. And when this occurs, then you need to take or withdraw aspirin from their medication regimen immediately. In most cases, especially if they didn't have anything prior, then if you take away the aspirin, the kidney function will then slowly return back to baseline. The risk for acute renal impairment can be reduced if you are able to first identify those patients that are at high risk and treat them with the smallest dose possible for their situation. Additionally, with renal function, aspirin can pose a risk for renal papillary necrosis and other types of renal injury when you're using it long term. So, as just a rule of thumb, anybody with already high risk for renal injury or decreased renal function, you would typically stay away from prescribing aspirin. All right, let's take a second look at our prototype drugs. The cyclooxygenase inhibitors or COX inhibitors, we've already discussed again what first and second gen NSAIDs are. So as a reminder, aspirin and ibuprofen are our prototype drugs for the first gen because these are non-steroidal anti-inflammatory. And then the second generation NSAIDs, these are selective only to the COX-2 inhibitor. Okay, so these are the drugs like Celebrex or Celecoxib, sometimes referred to as the COX-SIBs. So what makes a difference is that the second gen NSAIDs are selective to COX-2. And lastly, the drugs that lack this anti-inflammatory action, so it becomes in its own class, is acetaminophen. These are the 4 drugs that serve as the prototype. So let's look at a first generation NSAID. We're going to look at aspirin. Now, these first gen NSAIDs, again, they're widely used largely because they can inhibit COX-1 and COX-2. Traditionally, these NSAIDs were used to treat inflammatory disorders like rheumatoid arthritis, osteoarthritis, and sometimes bursitis. They can also be used to alleviate mild to moderate pain. And then lastly, they can be used to suppress fever. They have that fever reduction property, again, because COX can be found in the brain. First gen NSAIDs are also used to relieve dysmenorrhea. Because they don't inhibit COX-2 without also inhibiting COX-1, they can't suppress inflammation without posing risks for harm. So again, NSAID-induced ulcers are a common side effect, and they're responsible for more than 100,000 hospitalizations and up to 10,000 deaths each year. Aspirin, serving as the prototype drug, is the oldest member of this first gen NSAID family. It's highly valuable and a highly effective medication. Aspirins are said to provide excellent relief of mild to moderate pain, reduce fever, and protect against thrombotic disorders. So as I'm speaking very slowly and talking through what they're used for, think back and try to associate this and remember why. Because the COX is found in the tissues of our, or located in the brain, reducing fever, pain receptors, and also within the blood vessels, right? So they're protecting against thrombotic disorders. So largely, aspirin still is one of the drugs of choice for rheumatoid arthritis, and we'll be talking about that in more depth in another lecture. Now, despite new NSAIDs, it still is one of the most widely used of the first gen NSAID group. NSAIDs come in a variety of different strengths as well, and yet aspirin remains to be the standard agent against the others. Aspirin itself belongs to a chemical family known as salicylates. So sometimes aspirins get mistaken for not being an NSAID because you're used to seeing it as belonging to this other subclass, salicylate. But that's just the chemistry family or the chemical family. It still is a first gen NSAID because it's a non-steroidal anti-inflammatory drug. Aspirin is produced by substituting an acetyl group onto salicylic acid. And because of this group, it's commonly known as acetylsalicylic acid, or ASA. And so that abbreviation, ASA, isn't referring to the name aspirin, it's referring to acetylsalicylic acid. Specifically, the mechanism of action here is non-selective, and the most beneficial effect is the reduction of inflammation, pain, and fever. And this is directly because of the inhibition of COX-2. However, with COX-1 inhibition, we are able to protect against MI and ischemic stroke. Okay, so this should start to sound pretty repetitive now as we've worked through it on a very broad scale, and now we're bringing it to a very specific just to aspirin. So test yourself. What is the major adverse effect now? Hopefully you said GI ulceration, bleeding, and renal impairment, and you can identify that that's through the inhibition of COX-1. It's important also to know that aspirin is an irreversible inhibitor of cyclooxygenase. Okay, so this is what sets it also apart, because in contrast, the other NSAIDs can be reversible. Because the inhibition of COX by aspirin is irreversible, the duration and action of the drug really depends on how quickly the tissues synthesize new molecules of COX-1 and COX-2. With the other NSAIDs, the effects of the drug decline as soon as the drug levels decline. This is something that's different. COX, first-gen aspirin, so first-gen COX inhibitor, aspirin is absorbed rapidly and completely when giving an oral dose. And that principal site of absorption is within the small intestines. However, aspirin can also be administered through a rectal suppository, which there it is absorbed slowly, and the blood levels are lower than oral dosing. Aspirin has a very short half-life, only about 15 to 20 minutes, and this is because there is a rapid conversion of salicylic acid. The rate of inactivation of salicylic acid really is going to depend on the amount that is present in the body. So at low therapeutic levels, salicylic acid has a half-life of about 2 hours. But at very high therapeutic levels, aspirin can actually exceed a half-life of 20 hours. Salicylic acid is extensively bound to our plasma albumin. So therefore, binding is between 80 to 90% at therapeutic levels. It will undergo distribution to all our body tissues and fluids. This means that it will also be distributed to breast milk, fetal tissue, and the CNS. So let that help guide you into your patient education. It's excreted through the kidneys. And note that salicylic acid is highly dependent on our urinary pH. So if we raise the pH of our urine from, let's say, 6 to 8, we actually can increase the rate of excretion about 4-fold. In terms of actual plasma drug levels, low therapeutic doses of aspirin will produce a plasma salicylate level of less than 100 micrograms per milligram. However, if you're dosing it for an anti-inflammatory reaction, then it's going to produce salicylate levels of about 150 to 300 micrograms per milliliter. What would you look for in terms of toxicity? So some signs of what we call salicylism toxicity will actually begin when the plasma salicylate levels exceed 200 micrograms per milliliter. Severe toxicity is going to happen over levels of 400 micrograms per milliliter. Let's now summarize the therapeutic uses of aspirin. In terms of the suppression of inflammation, again being a choice drug for arthritis, it's also indicated for other types of inflammatory disorders like rheumatic fever, tendinitis, and we talked about bursitis. And usually the dosages that we're going to use to suppress inflammation are larger than the doses that we're going to use for just analgesia or even the reduction of fever. The precise mechanism of action in which aspirin decreases inflammation has not yet been established. But what we do know is that prostanoids contribute to the other components of the inflammatory process. So by inhibiting COX-2, we're actually providing a partial explanation of the anti-inflammatory effect, but not the whole reason. But there's some other possible mechanisms that are being explored, like the modulation of T cell function or the overall suppression of the inflammatory cell infiltration. How does aspirin provide analgesia? Again, only for mild to moderate pain. And this degree of analgesia depends on the type of pain. So if it's joint pain, muscle pain, or headaches, this is actually going to become more active against those type of pains. Now, aspirin can be more effective than opioids for other types of pains like post-operative pain. However, it's relatively ineffective against severe pain of any type of visceral origination. In contrast to opioid analgesics, aspirin does not produce tolerance to the drug nor physical dependence. So this is another plus for the use of aspirin for those that are not contraindicated. And we do this primarily through actions in the peripheral system. At sites of injury, those prostanoids will sensitize the pain receptors to the mechanical and chemical stimulation. And it's going to reduce pain by inhibiting COX-2. So if we give a COX-2 inhibitor, we're suppressing the prostanoid production. In the peripheral mechanism, aspirin works also in the CNS to help relieve pain. Well, what about the reduction of fever? Actually, aspirin is a drug of choice for fever reduction in adults. However, because of the risk of Reye syndrome in children, you should never use aspirin. It should never be used to treat fever in children. Yet, although aspirin can readily reduce the fever, it's not going to lower the normal body temperature, and it's not going to lower the temperature that has already become elevated in response to physical activity or a rise in environmental temperatures. Do you remember that body temperature is regulated by the hypothalamus? So this is an area of the brain that maintains a balance between the heat production and heat loss. So when the fever occurs at a set point of the hypothalamus, it will become elevated, causing the hypothalamus to increase heat production, but decrease heat loss. That set point elevation is triggered by the local synthesis of prostaglandins that are in response to endogenous or body-made pyrogens. So anything that is promoting the fever. Aspirin will lower the set point of the hypothalamus by inhibiting COX-2. Thereby, the net effect is the inhibition of the pyrogen-induced synthesis of prostaglandins, reducing the fever. And then lastly, we're talking about platelet aggregation. So aspirin suppresses platelet aggregation through the synthesis of TXA2, promoting aggregation. Aspirin suppresses platelet aggregation by causing an irreversible inhibition of COX-1. COX-1 is needed to make TXA2. And because platelets lack the machinery to synthesize new COX-1, the effects of even one dose persists for the life of that single platelet. Platelets live about 8 days. Okay, I'm going to repeat that process just in case you missed it, remembering that aspirin suppresses platelet aggregation by synthesizing TXA2. Remembering TXA2 stands for thromboxane A2, right? And this is going to bind to other protein receptors on the platelet. And this aspirin suppresses this aggregation, causing irreversible inhibition of COX-1, making it so that the enzyme that makes TXA2 is suppressed. Now, there is a lot of evidence that demonstrates aspirin, through its antiplatelet actions, can actually benefit a variety of different types of patients. And this information is according to the U.S. Food and Drug Administration, or the FDA. And they are recommending that there is a wider use of aspirin for antiplatelet effects. And now they're labeling daily aspirin for men and women with the hopes to reduce ischemic stroke, transient ischemic attacks, or TIAs, acute MI, previous MI, also being used to treat chronic stable angina and unstable angina. Also, they're saying it's safe to use for angioplasty and other types of revascularization procedures. According to a review in the Journal of American Medical Association, aspirin dose for the prevention of cardiovascular disease, that's the title of the paper. It said that a dose between 75 to 81 milligrams a day is indicated for these types of reasons, and it will actually prevent cardiovascular disease. The higher doses are commonly prescribed will have no greater protection for cardiovascular disease risk reduction, but will increase the risk for GI bleeding. And that's why it's very common to see doses like 81 milligrams a day for our cardiac patients or patients that are at risk for cardiac damage. If you are wondering how to calculate the risk for patients in cardiovascular event, there is a medical calculator. You can go to the website cvriskcalculator.com, and it actually, by adding in answers for questions regarding your patient, you can see the 10-year risk for a cardiovascular event. So again, how likely are they to have a stroke or MI? One more thing is that aspirin has been shown for cancer prevention, specifically colorectal cancer, and there is good evidence for this as well. And in a report from the Lancet, it actually indicated that the use of low-dose aspirin, and they're referring to low dose as 75 to 300 milligrams a day. So it's a much wider range. But if you're using that for more than 5 years, it reduces the incidence of colorectal cancer by a whopping 24%. And it actually will also reduce mortality by 35%. So it does appear that prevention is effective when you prescribe patients 81 milligrams. And this is effective so you don't have to prescribe these larger doses. Low doses do provide the benefit of cancer protection for colorectal cancer with the reduction of the other adverse effects. How does this do this? Aspirin protects against colorectal cancer by inhibiting COX-2. And we saw in animal models, COX-2 promotes tumor growth and metastasis by the inhibition of COX-2, which slows tumor growth as well. Now, aspirin doesn't protect against colon cancers with little or no COX-2. So these are the only ones that are responding to aspirin protection is those types that express the COX-2. since we've already talked in some depth about the first three side effects here that I have listed, we're going to spend some time talking about salicylism and Rey syndrome, as well as drug interactions. Now, salicylism is a toxicity or a syndrome that develops when aspirin levels climb above their therapeutic levels. And if you're wondering what those levels are, refer back to the last slide, and it tells you the difference between the types of toxicity. So, what are you looking for? Tinnitus, swelling, headache, dizziness. You might even see disturbances in the acid base balance as well. And if this type of toxicity develops, you have to stop the aspirin immediately until all the symptoms subside. Now, if the provider wants to resume the use of aspirin, you're going to have to use aspirin in smaller doses. So, that small reduction in dosage is going to be depending on how much was prescribed to get to that certain therapeutic level in that patient. Now, in some cases, the tinnitus that develops can also help to be used to adjust aspirin dosage. So, what do I mean by that? When tinnitus occurs, the maximal acceptable dose has then just been achieved. So, then you're going to make sure that you bring down that dose. However, the guidelines may be inappropriate for older patients because they fail sometimes to develop this symptom of tinnitus. So even when the aspirin levels become toxic, you may not catch that first symptom. So think about that with the aging population. Now, in terms of acid base disturbances, this is from the effect of aspiration on our respiratory system. When we administer aspirin in high therapeutic doses, it acts on our CNS to stimulate breathing. So, what is the net result? It's actually going to increase CO2 loss production. And when we are losing more CO2 than we need be, this can result in respiratory alkalosis. Well, then the kidneys have to respond, right? Because we're talking about acid base. So then the kidneys are responding now by excreting more bicarbonate. This is also a subsequent buildup of acid producing a resultant now metabolic acidosis. So patients who present with this type of toxicity can oftentimes have a mixed acid base imbalance, right? So first on the respiratory system, producing respiratory alkalosis by the loss of CO2. And then the kidneys kick in, excreting more bicarbonate. And then we have the buildup of acids resulting in metabolic acidosis. And then Rey syndrome. You probably remember, even from nursing school, that Rey syndrome is associated to the childhood taking of aspirin. Okay, so never prescribe aspirin to anyone under than 18 years of age. The mortality rate is somewhere between 20 to 30 years old with somebody that has Rey syndrome from aspirin. So, what are you going to look for with Rey syndrome? Encephalopathy, fatty liver degeneration. You might even note that there is some data that suggests a relationship between Rey syndrome and the use of aspirin by children who also have influenza or chickenpox. So they're at a greater risk for Rey syndrome if they are a pediatric patient and they were given aspirin for influenza or chickenpox. Now, there's a direct causal link between aspirin and Rey syndrome that hasn't really been well established. So this is not like a aspirin then Rey's, directly. However, because of what research is already pointing to, the CDC recommends that aspirin and other NSAIDs actually be avoided by any child or teenager that has flu or chickenpox or suspects to have influenza or chickenpox, right? So if you're kind of even on the fence of wondering if they are positive for flu or varicella, then you will not even prescribe, in addition to aspirin, any other type of NSAID. So in response to this CDC recommendation, aspirin was removed from most products that were intended for the pediatric population. And by this, the use of aspirin in children has declined sharply. So we see less Reye syndrome. And it's essentially not something we see at all. However, if you do see symptoms associated to Reye's, then you would first suspect aspirin toxicity. Going back to how it may affect the fetus, aspirin crosses the placenta. Okay, so there is an adverse effect that can occur. Because prostaglandins help keep the ductus arteriosus patent, when we inhibit prostaglandin synthesis by using aspirin, we're actually going to induce a premature closure of the ductus arteriosus. So you wouldn't want to do this. Knowing this, we also find that for patients that have a patent ductus arteriosus, a large one that's causing respiratory issues in the NICU, we might prescribe an NSAID to help with this closure. But we wouldn't want to do it prematurely. So this would only be in the direction of a neonatologist or neonatal nurse practitioner. Aspirin has been also associated with low birth weight, stillbirth and renal toxicity, as well as intracranial hemorrhage when used in preterm infants, and also neonatal death. So this is not a drug for infants as well. Should not be prescribed without the consultation of a physician or cardiologist. So let's summarize the precautions and the contraindications now. Remember, we don't want to give aspirin to patients with a known GI disorder like peptic ulcer disease or a known bleeding disorder like hemophilia, vitamin K deficiency. We don't want to give it to any patient that already has a known hypersensitivity to aspirin. Additionally, we want to use it extremely conscientiously by pregnant women and other children who may have chickenpox or influenza, because it may have an effect towards Reye syndrome. We should also be cautious with treating older patients. We should also be cautious with aspirin for any patient who's ever smoked cigarettes, or if they've had H. pylori infection, heart failure, cirrhosis, renal dysfunction, any patients that have severe asthma, hay fever, chronic urticaria, nasal polyps, or a history of alcoholism. This is also going to be contraindicated. When should aspirin be withdrawn? For surgeries. If it's an elective surgery, they need to start withdrawing their aspirin about 1 week before the elective surgery. Or if it's a low dose aspirin, then check with their cardiologist if it was prescribed from them. But usually with low dose aspirin, if it's a low risk procedure like a dental procedure, there's no need to reduce their 81 milligrams of aspirin. We're going to spend a little bit more time here on this slide talking about aspirin interactions with other drugs. The first class are the anticoagulants like warfarin and heparin. Because aspirin suppresses platelet function, it can decrease prothrombin production, which will then intensify the effects of warfarin, heparin, and the other anticoagulants. So we wouldn't necessarily consider giving someone aspirin while they're on an anticoagulant. Also, because aspirin can irritate gastric bleeding, it can also augment the anticoagulant effects. It really increases the risk for gastric hemorrhage with these patients. So, the combination of aspirin with anticoagulants, if they need to be used, you need to be using it very carefully. Even when aspirin is taken in low doses, like an 81 milligram, you also want to watch and see, can I really prescribe this aspirin if this patient is on an anticoagulant? I myself would say no. A cardiovascular specialist may perhaps have a different opinion, but keep in mind what it's doing to prothrombin production and increasing the risk of gastric hemorrhage. With glucocorticoids and aspirin, we are also in combination promoting a higher risk for gastric ulceration. Now, if you're wondering, in what circumstance would someone need a glucocorticoid and an aspirin, this is something that may be prescribed when you are treating arthritis or managing arthritis. So if you need to provide a glucocorticoid and an aspirin, you want to reduce the risk of ulceration by also prescribing a proton pump inhibitor or an H2 receptor antagonist. And this is going to provide prophylaxis to the GI system. When combining aspirin with alcohol and other NSAIDs, it really does increase the risk for GI bleed as well. So, to help the public know about this risk, the FDA now requires that all labels for aspirin and NSAIDs and acetaminophen, it might say stomach bleeding warning. This product contains an NSAID which may cause severe stomach bleeding. Specifically with alcohol, the chance is higher if you've had 3 or more alcoholic drinks every day while using the product. However, I do educate my patients that if they are using aspirin, they may want to strain from the combination of alcohol with their aspirin treatment. If a patient is on aspirin and they also need an NSAID for their non-steroidal anti-inflammatory effects or fever reduction effects. For instance, someone is on aspirin for like a low-dose aspirin for cardiovascular disease prevention, but now needs something for pain. A provider might prescribe ibuprofen, naproxen, or they might get that over the counter. But when you're taking those drugs, it reduces the antiplatelet effect of the aspirin, because it's blocking access to aspirin to the COX-1 found in platelets. Well, how could we still provide the same effect that we're trying to achieve without compromising the role of aspirin? We can give it 2 hours before giving the ibuprofen. Right? So we can say, okay, take your aspirin in the morning at 7 a.m. and don't take your NSAID until 9 a.m. or later. Right? And this can interfere that interference, because when we give aspirin, it is immediate releasing and it's going to produce complete platelet inhibition in about an hour. So as soon as you give it, an hour later, it's doing what we want it to do anyways. So if we wait 2 hours later, give the NSAID, we can eliminate that interference. However, you can also just use a higher dose of aspirin rather than giving an NSAID and an aspirin. By giving a higher dose aspirin, you're achieving the suppression of platelet aggregation, and also you might be providing the other benefits that NSAIDs provide. For patients that are taking an ACE inhibitor or an ARB, by giving aspirin, you're also going to impair renal function. We know all 3 drugs do this. So with patients that are highly susceptible to renal dysfunction, when you combine aspirin with those drugs, ACEs and ARBs, it can increase the risk for acute renal failure. High-dose aspirin should be avoided in patients that are taking ACEs and ARBs. However, providing a low-dose 81 milligram aspirin for an antiplatelet effect can be continued. And so sometimes you will see patients on an ACE inhibitor or an ARB, and they will have an 81 milligram dose of aspirin. They should not be taking higher doses. So keep in mind, if your patient has arthritis plus hypertension, this is something that you would want to consider while treating their arthritis, or perhaps you might have to change their blood pressure medication. And then lastly, in terms of vaccine interactions, aspirin and other NSAIDs may blunt the immune response to the vaccine. So Drugs that do this should not be routinely used to prevent vaccination-associated fever and pain. And quite often, we will see patients taking an NSAID to relieve their fever and pain associated with getting a vaccination. But instead, think about the other class of medication that we can use to reduce fever and pain that is not aspirin and NSAID. So if you said acetaminophen, here you are correct. This chart here, I would refer you back to your textbook to get a better look at table 57.4, but you can see the clinical pharmacology of the oral type NSAIDs, and this will tell you what the maximum dose is and the half-life, the indications, etc. It is very important that you recognize the maximal daily dosages for these drugs. So for aspirin, 8,000 milligrams is the max dose per day. For ibuprofen, it's 3,200 milligrams max dose per day. Naproxen, so this is Aleve, this actually is 1,375 milligrams per day, so a lot lower than Advil or Motrin. I'd also want to bring you down to Celebrex. 800 is the maximum daily dose per day. So take a look at this chart or table in your textbook. Now we're going to move on to ibuprofen. We still are under the first generation NSAID class, and this drug actually came to be an attempt to produce the same effect that aspirin produces, however, having a lower risk for GI, renal, and hemorrhagic effects. The pharmaceutical industry produced a very large number of drugs that had similar actions to aspirin. And actually, here in the US, there's more than 20 NSAIDs that are not aspirin that are available. And that was the previous table that we just saw. Now, like aspirin, all these first-gen NSAIDs are, again, inhibiting both COX-1 and COX-2 because first-gen NSAIDs are not selective. But in contrast to aspirin, remember, aspirin causes irreversible inhibition of COX. These traditional NSAIDs can reversibly inhibit COX. So all of these drugs will have anti-inflammatory characteristics, analgesic, and antipyretic properties. So antipyretic meaning lowering fever or reducing fever. However, we do want to remember that these non-aspirin NSAIDs still have risk for gastric ulceration, bleeding, and renal impairment. Although the intensity of these effects can be less with some of these NSAIDs than others. So you want to look at the chart in 57.4. Now, anybody that is hypersensitive to aspirin, they're likely also going to be hypersensitive to other NSAIDs. So that cross hypersensitivity needs to be one of your prescriber considerations. For most NSAIDs, they can be safe during pre-pregnancy. However, if you know someone is trying to get pregnant or pregnancy has already been confirmed, then you don't want to prescribe NSAIDs. We don't have enough information, so we really discourage the use of any NSAID during pregnancy. What is the principal indication for someone using a non-aspirin NSAID? Typically, it's rheumatoid arthritis and osteoarthritis, like we've discussed. Now, certain NSAIDs are used to treat fever, tendinitis, and again, mild to moderate pain. And we talked about dysmenorrhea and fever reduction, again, also found in the previous chart. Now, to contrast aspirin, the non-aspirin NSAIDs do not provide any protection against MI and stroke. In fact, they can actually increase the risk of a thrombotic event. So, for NSAIDs as a whole group, the increase in cardiovascular risk is relatively low, though, only about 12%. The highest NSAID risk is with indomethacin. Actually, this is at 71% for a thrombotic event. However, although the increase in risk with these drugs appears really high, it still pales in comparison to the risk from smoking, which increases cardiovascular risk by 200 to 300%. So just to give you some perspective on that. To minimize our cardiovascular risk, non-aspirin NSAIDs should not be used in the should not be used in the highest dose for the longest time, right? So we also want to use the principle of low and slow. We want to use the lowest effective dose possible for the shortest amount of time to relieve the symptom. These drugs should not be used before any type of coronary artery bypass surgery or 14 days after the CABG. We also want to think about how we have these type of NSAIDs are really different chemically, pharmacokinetically, and to some extent, even the pharmacodynamics are different. Although, clinically, they're very similar, and they will all produce essential equivalent anti-inflammatory effects, still all present a similar risk for the adverse effects. Again, gastric ulceration, bleeding, renal impairment, MI, and stroke. But though we don't understand, there are other reasons why some patients just respond better to one type of NSAID than another type of NSAID. One patient may tolerate ibuprofen better than a different type of first generation NSAID. And so it really is trial and error. But with any drug that you are prescribing, you want to use the low and slow technique. So lowest amount possible for the shortest duration of time. And then to optimize therapy for each patient, you might need to trial more than one NSAID. In terms of the basic pharmacology of ibuprofen, so again, these brand names are Advils and Motrins, you want to see that these drugs, or ibuprofen, is the prototype of the propionic acid derivative. And these are going to be discussed right now. Okay, so ibuprofen, propionic acid derivative. So like aspirin, ibuprofen inhibits COX and has anti-inflammatory, analgesic, and antipyretic actions, but when we use the drug to treat fever, mild, moderate pain, and arthritis, additionally, ibuprofen appears superior to the other NSAIDs for some of this. And also, specifically for the primary reduction for dysmenorrhea, NSAIDs are superior. And this is because it produces good inhibition of COX within the uterine smooth muscle. And not all COX inhibitors do this. So ibuprofen is one that works on the uterine smooth muscle. It's also very effective at promoting the closure of adductus arteriosus, so someone with a PDA, an infant. Using indomethacin is the first-line current treatment of choice. This drug is generally well tolerated, and adverse effects are pretty low in incidence. It can produce gastric bleeding, but less than aspirin and even less than other types of NSAIDs. It also produces less inhibition of platelet aggregation. So, in summary, ibuprofen is among the safer NSAIDs for use, even with anticoagulants. And very rarely, though, ibuprofen has been associated to Stevens-Johnson syndrome, remembering that this is a very severe hypersensitivity reaction. You'll see skin blistering, mucous membranes will be exposed, and it can result in scarring, blindness, and even death. Okay, so Stevens-Johnson syndrome. And like other non-aspirin NSAIDs, we do still have a risk for MI and stroke. This does not reduce that risk. The black box warning for first generation non-steroidal anti-inflammatory drugs is that it does become a risk factor for GI bleeding, cardiovascular events that can lead to hospitalization or death. Before this lecture ends, we do need to touch on the second generation NSAIDs, and these are the selective COX-2 inhibitors, sometimes referred to as COXIBs. And in theory, they were first developed because we were trying to find a NSAID that would provide all the benefits of the first generation NSAIDs, but hopefully reducing the risk for GI bleed. And it does pose a somewhat lower risk for GI side effects. However, even with these COXIBs or selective COX-2 inhibitors, they can still cause significant gastroduodenal ulceration and bleeding in some patients. We also know, just like the traditional NSAIDs, they can impair renal function and thereby cause hypertension and edema. And they do increase the risk for MI and stroke. So the opposite of what aspirin does. So what is the therapeutic use for Celebrex or the second generation celecoxib? We will use it for arthritis, osteo and rheumatoid. We also use it for juvenile idiopathic types of arthritis. We can use it for acute pain, and dysmenorrhea is also an indication for Celebrex. For patients with arthritis, the amount of Celebrex is equal to naproxen in terms of relieving joint pain, stiffness, and swelling. So if you're thinking about the concerns regarding cardiovascular safety, Celebrex is considered a last choice drug for long-term pain management. And this is under the American Heart Association statement on COX inhibitors for chronic pain. It's also important to note that celecoxibs don't provide the cardiovascular benefit of aspirin because they don't inhibit the COX-1 in the platelet. So they're not going to suppress platelet aggregation, right? So you need something that is working directly on COX-1. But since this is a selective COX-2 inhibitor, it's not going to do anything with the platelets. It's not going to suppress platelet aggregation. Therefore, again, does not provide cardiovascular benefits. And actually, we see from my statement earlier that it increases the risk for MI and stroke. In terms of pharmacokinetics, it is well absorbed through oral administration. It peaks in about 3 hours, so plasma levels are its highest 3 hours after administration, and it does bind extensively to our plasma proteins. It undergoes hepatic metabolism and is followed then by renal excretion. Half-life is about 11 hours. We have talked pretty extensively about the GI, cardiovascular, and renal adverse effects. So I will just touch on in more detail now, moving on to the sulfonamide allergic reaction. So patients that are allergic to sulfonamides may also have a cross reaction to celecoxib because celecoxib contains a sulfur molecule. And so it can precipitate an allergic reaction in patients that have a known allergy to sulfonamides. In terms of pregnancy, celecoxib and the other NSAIDs actually can cause, again, premature closure of the ductus arteriosus. We've seen that, right? So we don't want to give it to patients that are pregnant because this can close the ductus arteriosus before the baby is able to breathe on their own and get oxygenation through the lungs. So these drugs are contraindicated during the 3rd trimester of pregnancy. And warfarin, in terms of drug reaction, actually with celecoxib, it can increase the anticoagulant effect of warfarin and increase the risk for bleeding. So Celebrex should not be used, or can be used very carefully, with patients that are on warfarin. Celebrex itself will not inhibit platelet aggregation. We know this from earlier, but it does not also promote bleeding. Yet, it can enhance the anticoagulant effect of warfarin. So Celebrex in itself isn't going to cause the risk for bleeding, but it's actually intensifying the effect of warfarin in combination. It's increasing the warfarin level. So if it's used in combination with warfarin, it needs to be monitored very closely, especially within the first few days of treatment, because the warfarin dose may need to be adjusted. If you don't need to take Celebrex with warfarin, that's probably the best option. Other interactions to think about in terms of Celebrex with other drugs, it's pretty limited, but we do know that Celebrex can decrease the diuretic effect of Lasix or furosemide. It also can decrease the antihypertensive effects that we're looking for when a patient is taking an ACE inhibitor. So if patients are taking Lasix or ACE inhibitors, you may also want to stay away from celecoxib. Now let's look conversely now. Celecoxib can increase levels of lithium, and lithium is a drug that we use for bipolar disorder. And if you are using lithium, the levels of Celebrex may be increased. The levels of lithium will actually increase. If you're using an antifungal drug like fluconazole, the levels of celecoxib can be increased by the fluconazole. So let me say that again. If you're using lithium, using Celebrex will increase the lithium. But if you're using fluconazole, the fluconazole is increasing the levels of Celebrex. And lastly, in terms of patient-centered care across the lifespan, for infants, again, we're talking globally here for non-steroidal anti-inflammatory drugs. You don't want to give infants aspirin due to Rey syndrome. And acetaminophen and ibuprofen can be used safely in small doses for the management of fever. For our children and adolescents, again, you are avoiding aspirin for anyone under 18 years old, and acetaminophen and ibuprofen can be used again in small doses. For pregnant women, because of the premature closure of ductus arteriosus, it is contraindicated in the 3rd trimester. And breastfeeding women, taking NSAIDs and acetaminophen appear to be safe in the levels of milk. And other adults that we're thinking about is our older population. So NSAIDs, which are commonly used to treat pain in our older population, we also want to make sure that they understand the daily recommended dose. And we have seen that use of these drugs increase hospitalization, and they can contribute to elevated blood pressure. They can precipitate CHF, decompensation, and also provoke renal failure. So we want to use this drug class with extreme caution in our older population. We're at the home stretch. We're going to talk about acetaminophen now, remembering that acetaminophen, just like aspirin, can provide analgesic and antipyretic properties, right? However, in contrast to aspirin and other NSAIDs, acetaminophen will not provide anti-inflammatory or anti-rheumatic actions. Lastly, acetaminophen will not suppress platelet aggregation. It doesn't cause gastric ulceration, and it doesn't decrease the renal blood flow or cause renal impairment. What we want to be aware of, though, The difference here is that acetaminophen can cause severe liver injury in overdose. So in the US, acetaminophen is used more than any other analgesic because it is thought to have a safer drug profile. And how it works is, thinking about the mechanism of action, the difference between the effects of acetaminophen and aspirin, both are thought to result from selective inhibition of COX and also the inhibition of the enzyme needed to make prostaglandins and other related compounds. Yet, aspirin can inhibit COX in the CNS and the periphery, where acetaminophen is only limited to the CNS, and this is why it will only have minimal effects at the periphery. And so, by decreasing prostaglandin synthesis in the CNS, we're able to reduce fever and pain, but outside the CNS, we are not able to affect inflammation. But we're also not able to cause gastric ulceration or cause any adverse effects on the kidneys and the platelets. Again, limited to the CNS. In terms of pharmacokinetics, it's absorbed pretty readily with a PO dose, and it has a wide distribution. It's metabolized mostly by the liver and excreted in the urine, and it has a half-life of about 2 hours. It can be metabolized on 2 different pathways. The first one is a major pathway, the other one's a minor pathway. We're going to talk about the major pathway of conjugation with glucuronic acid and other compounds that are going to form a non-toxic metabolite. However, we should also think about the minor pathway because it's oxidized by cytochrome P450. And this is a highly reactive toxic metabolite, and we remember that from our intro classes. At therapeutic doses, all of the drug is converted to a non-toxic metabolite through the major pathway, and only a small fraction is converted to the toxic metabolite through the cytochrome P450 pathway. So under normal conditions, the toxic metabolite will undergo a rapid conversion to the non-toxic form. What does this mean? That it is relatively safe. But in the event of an acetaminophen overdose, so someone that has taken a larger than normal amount, it's going to be now processed through the major pathway, but also processed more heavily through the minor pathway. So this large quantity of toxic metabolites is produced through also the minor pathway. What happens is the liver attempts to clear the metabolite. However, it has already caused a toxic metabolite to accumulate, and this is causing the damage to the liver. In terms of therapeutic uses, we've already established that we can relieve pain and fever because it's acting upon the CNS and again, not the periphery. And it actually is safe in children because it's not related to Rey syndrome as well. And it's the preferred drug of choice for any child suspected to have a fever due to influenza or chickenpox. Because it doesn't cause GI injury, it's also preferred for patients with peptic ulcer disease. And it provides a safe alternative to patients that may otherwise have been exposed to aspirin and have a known hypersensitivity reaction to aspirin. Again, remembering that it does not readily reach the periphery and it lacks anti-inflammatory action, it's not useful for treating arthritis or rheumatic fever. In terms of Tylenol or acetaminophen, the adverse effects are extremely rare when used with a therapeutic range. And so acetaminophen isn't going to cause, again, gastric ulceration, renal impairment, or inhibit platelet aggregation, so we don't have to worry about those adverse effects. But we also know that if patients have liver disease or they're using high doses of acetaminophen, and they overdose, this is a situation that can cause severe liver injury. There's a study that shows that the daily use of acetaminophen of 500 milligrams a day or more can actually develop into hypertension. Additional studies have shown that there is a possible relationship between the use of acetaminophen and hypertension in men and women, but the results were conflicting with other studies. But it's just something to think about. But more data needs to become available to make a clear determination on this. However, with patients that are on Tylenol for long term or long periods of time, it would be a safe provider practice to monitor their blood pressure as well, knowing that there have been some conflicting studies out there regarding hypertension. We also know that acetaminophen has been associated to Stevens-Johnson syndrome as well. We know that it can produce toxic epidermal necrolysis, and these terms, SJS or Stevens-Johnson syndrome and TENS, toxic epidermal necrolysis, we will see with our patients that blistering skin, we also have blistering mucosa membranes, painful rash, and also severely we'll see detachment of the epidermis. So it is considered a medical emergency. It can result in death. So it's one of the higher risk adverse effects. Now, it can also cause another type of skin disorder called acute generalized exanthamatous pustulosis, or AGEP. And AGEP is characterized, or AGEP, I guess, AGEP, is characterized by pustular lesions, and predominantly you're going to find them on the upper body, the trunk, and the body folds. Usually resolves within 2 weeks of onset, so it's not as deadly as SJS or TEN. Other reactions that can occur over time with patients on acetaminophen can be a rash. And when this rash appears, many times providers are, looking to see if it's going to progress to these more dangerous or toxic type skin disorders. If a rash does appear while a patient is taking acetaminophen, then you want to stop immediately and you want to have them get a thorough assessment. In terms of drug interactions, if we want to lump alcohol into that, regular alcohol consumption does increase the risk for liver injury already. And then now, if a patient is taking acetaminophen, it will increase the risk of liver injury from the acetaminophen. But this is only if acetaminophen dosage is excessive. Remember that alcohol is an inducer of the P450 containing enzymes. And remember, this is the enzyme that is going to be part of the minor metabolic pathway. So when we're increasing the production of acetaminophen's toxic metabolites through the use of high dose acetaminophen and also the use of alcohol, we are accumulating toxic degrees of acetaminophen. As a result, the liver is not going to be able to convert this metabolite to the non-toxic form. Also, chronic alcohol use does often cause pre-existing liver damage, so you would not want to provide acetaminophen to patients with known liver damage. We also know that it is recommended that if you drink alcohol on a regular basis, then you should lower the consumption of acetaminophen to no more than 3,000 milligrams of acetaminophen a day. But best case scenario is that you are not drinking alcohol excessively and you're not using excessive amounts of acetaminophen. And although therapeutic doses of acetaminophen or Tylenol can be safe for patients that drink alcohol, of course, high doses are not. With drug interactions, warfarin is something to consider. There is evidence that while taking Tylenol or acetaminophen, it can increase the risk of bleeding in patients that are on warfarin. And this is because, unlike NSAIDs, acetaminophen does not suppress platelet aggregation. So it's not going to promote bleeding, but acetaminophen can actually inhibit warfarin metabolism. So it does work against warfarin, just like our other NSAIDs, but it's not through the suppression of platelet aggregation. It's because it's an inhibitor of warfarin metabolism. So if it's inhibiting warfarin metabolism, you have more warfarin in the body, it's going to cause these warfarin levels to rise. So patients that are taking more than 1 gram of acetaminophen a day for several days at a time can respond differently to warfarin. And so you want to monitor warfarin for increased levels. Acetaminophen and other analgesic type antipyretics can cause a blunt to the immune system in response to childhood vaccines. So routine use of these drugs to prevent vaccination-associated pain or fever should be discouraged. However, I would say that many pediatric providers do recommend, if you are going to use a type of pain relief or fever reduction, they prefer acetaminophen over NSAIDs. But know that it can blunt the immune response that you are looking for. Acetaminophen use can cause acute toxicity like liver damage, and it can actually be so severe that it can cause death. And it is through the accumulation of the toxic metabolite that we talked about earlier, not being able to clear the different pathways. Risk for liver injury is increased if your patient is fasting, if they use alcohol chronically, or they're taking more than 4 grams of acetaminophen every day. So what are you looking for in terms of signs and symptoms? If you are suspecting acetaminophen overdose, this may be hepatic necrosis. So severe poisoning can progress to hepatic failure, coma, and death. So all of those symptoms are related to hepatic necrosis. Now, what are the early symptoms that you're going to look for to avoid hepatic failure? You're going to look for nausea, vomiting, diarrhea, sweating, and abdominal discomfort. These are all believed to be due to intoxication from Tylenol or acetaminophen. And it's not until about 48 to 72 hours after taking the drug that you're going to see any overt hepatic injury. If this happens, there is a treatment to help minimize the damage, and you can give Mucomyst. And Mucomyst is the antidote for a Tylenol overdose or acetaminophen overdose. And this is acetylcysteine. Acetylcysteine reduces injury by substituting for the depletion of glutathione in the reaction that converts to the toxic metabolite. And with this substitution, then it can help to turn acetaminophen into the non-toxic form. And if we give it within 8 to 10 hours of acetaminophen overdose, this antidote, Mucomyst or acetylcysteine, is usually 100% effective, and it can prevent severe liver injury. Even though if you give this antidote within 24 hours of poisoning, it still has some significant protection. You want to give it orally or intravenously. Overall, in terms of patient teaching and trying to minimize the risk for liver damage, you want to make sure that your patient is at a very low to normal therapeutic dose, so up to 4 grams. Except in people that drink, then you want to make sure that you are actually even giving lower or none at all. For patients that are undernourished or have liver disease, you also will reduce this amount. Inform your patient about the risk for liver toxicity. Make sure they're not consuming more than 400 milligrams or 4 grams of acetaminophen a day, including combinations that could be found in other combination drugs for pain, like Vicodin or Percocet. They also have acetaminophen in it. And other over-the-counter products like cold and flu medications, they also may have acetaminophen under their ingredient list. Advise patients that are undernourished, so someone that is undernourished because they are ill or perhaps even fasting, that if they consume more than 3,000 milligrams or 3 grams of acetaminophen a day, this also puts them at more risk for liver disease. Anyone who's drinking alcohol, obviously tell them the risk. And for patients who cannot stop drinking alcohol or refuse to stop drinking alcohol, and they're having more than 3 drinks a day, they should also be limited to 3 grams or 3,000 milligrams of acetaminophen a day. Overall, use your best judgment to advise these patients with liver disease. They are going to ask you as a prescriber if acetaminophen is safe, so make sure that you know the therapeutic doses for their situation. And we are wrapping up now. You can see the summary of key prescribing considerations here for acetaminophen in a bite-sized chunk here. This is something that you want to review for the exam.